Okay, let's start with our first case. An 82-year-old male presents to the emergency room complaining of dyspnea. He reports that he woke up this morning feeling as if he was unable to catch his breath. He denies any chest pain, cough, fever, nausea, or diaphoresis. His past medical history is significant for long-standing hypertension and type 2 diabetes mellitus. An EKG demonstrates ventricular tachycardia. His blood pressure is stable at 148/80. You try to convert this patient to sinus rhythm using amiodarone and lidocaine, but you are unsuccessful. The patient adamantly refuses electrical cardioversion. You decide to try another agent to treat the patient's arrhythmia, although you worry that long-term use of this medication may lead to a lupus-like syndrome. So this is the key point here, that it may lead to a lupus-like syndrome. So the class 1A antiarrhythmic agents include quinidine, procainamide, disopyramide. So the mechanism of action here is that they bind to the activated sodium channels, blocking the flow of sodium ions into the cardiac myocyte. And by blocking activated sodium channels, phase 0, depolarization of the cardiac action potential is prolonged, thereby slowing the rate of conduction of the action potential and thus the rate of cardiac muscle contraction. Phase 3 repolarization is also delayed by a small interaction of the class 1A antiarrhythmic agent with potassium channels. This interaction results in a longer refractory period for the cardiac myocyte, and thus the cardiac myocyte is unable to fire as frequently. So clinical uses, atrial fibrillation and ventricular tachycardia. Side effects, these actually may cause cardiac arrhythmias. GI upset, vertigo, headache, tinnitus, psychosis. With procainamide, drug-induced lupus, psychosis, and I'm not going to talk about all of the things, but these main things here, that they are sodium channel blockers, these class 1A antiarrhythmic agents used for atrial fibrillation and ventricular tachycardia.